Assalamu alaikum. The short clinical day. We'll start with this first scenario. Dr. Muhi will present the patient. Then Dr. Mayada will start examination. Please, Dr. Muhi.
Look to the face, then examine neurologically according to your impression from the photo. Examine the target neurological sign.
Yes, I share the photo, Dr. Mayada. You can see the screen now?
Yes.
Okay, I will start timer in my stopwatch. You can start now.
Okay, so first I want to examine I will start my examination by examining the cranial nerves in this lady. First, I will examine the optic nerve. I want to examine the visual acuity and the visual field.
Examiner told you no need.
No need. Okay, then I want to examine the pupillary reflux.
No need.
And fundoscopy. This is for the first cranial nerve. Then I will examine. No need. Okay. Then I want to examine the movement of the eye to examine the third, 7, and 4 cranial nerves. I can see ptosis. Patient has ptosis, yeah?
Yes.
Is it bilateral or unilateral?
Bilateral, yes. Bilateral ptosis.
Bilateral ptosis. Then I want to examine the other movement for the third cranial nerve.
What you give me the order? What you
diplopia. Diplopia. I want to examine for diplopia.
Diplopia, okay.
Okay.
There is no. Okay, there is diplopia, yes. Diplopia.
Okay. Okay. Then if there is any nystagmus.
Dr. Mayada, how you examine diplopia? Explain the steps.
Yeah, even the steps.
Yes.
Okay.
Yes.
Okay. So I will first I will ask the patient to follow my finger. This is and then I will ask if he can see double vision. He just let me know.
Okay.
I will go for the brief referees.
Okay.
In the 4, I will examine the eye like 4 quadrant. First, I will examine the upper quadrant of the eye, out quadrant, and the lower quadrant. If there is any diplopia while I am moving my finger.
No. He said no pain, no diplopia, no double vision on looking by each shape. Okay. Then proceed.
Yeah. Then I want to examine the pupillary reflux. I think this will be I want to.
Examiner told you no need. Examiner told you no need. Go. Proceed.
Okay. Then I will go further to examine the trigeminal nerve. Now, already examined the eye.
He told you no need. No need for trigeminal nerve.
Okay. Then I want to examine the facial nerve.
Yes.
By examining, I will ask the patient to raise the eyebrow.
Yes. How you will do this?
Sorry?
How you will do this?
I ask the patient to raise the eyebrow.
Okay.
And then to examine if there if it's flat or it is.
It is flat, yes. It is flat.
Bilaterally or unilaterally?
Bilaterally, yes. No wrinkles in the forehead.
Okay. Then I will ask him to close his eyes very tightly, and I try to pull it.
Yes, he cannot. Only the eye globe go turn up, and the whitish conjunctiva appear, and the eyelids is not going down to close the eyes. Okay.
Sorry, I couldn't imagine again. What happened? He can't.
You asked him to close the eyes. He cannot close the eyes firmly.
Okay.
Only the globe turned up. Okay.
Then I will ask him to puff his cheeks.
Yes, he cannot buff his cheeks.
Both or
Bilaterally.
unilateral?
Yes, bilateral.
Bilateral.
Okay.
Okay. Can he smile?
He cannot open his mouth good, and only the front teeth which appear. So he cannot smile properly bilaterally.
Mm. Okay. Then I want to examine the test in the anterior part of the tongue.
No
But
need. Examiner told you no need.
okay. Then I want to examine the 8th cranial nerve.
Yes.
I will do whispering test.
Yes, he is hearing good bilaterally.
And I want to do a rain test and whipper test
Only you
with
do
the tuning fork.
no need, no time for this. Only freckling in front of the ear. He said to you, I am hearing good.
Okay.
Okay.
Yeah. Then I want to examine for glossopharyngeal and vagus nerve. So I will ask the patient to say ah.
Yes, he said no problem.
And I want to check for
Check
the
the
palate elevation
Uvula.
and
You will
uvula.
you will see what?
I want to see for the palate elevation and uvula deviation, if there is any
No
uvula
deviation.
deviation.
It is intact. Yes, it is intact. No deviation.
Then I will do gag reflux.
Examiner told you no need. خلاص. It is normal.
Okay. Then apart from this, I want to examine the shoulder. Then I will examine the
Shoulder
11,
intact.
11, yeah?
Intact.
Shoulder.
Intact. Intact.
Okay.
Yes.
Okay, this is the cranial nerve. Then I want to, the only positive thing that he has bilateral facial nerve. Yeah?
No, yes, continue.
Yeah. Then I will
you-
examine, I will continue for the other neurological examination.
What you
I
will
will ask I will examine the upper limbs, the power. So I will ask the patient first just to raise his hand, his arms. He can raise his arms or no?
Oh, no, there is weakness. There is weakness bilaterally in the upper limbs.
Both upper limbs.
Yes.
Okay, so then I will do deep examination. First, I will start from his arms. I will examine the shoulder, the muscles around the shoulder joint. I will ask the patient to abduct if there is any weakness in abduction.
Yes, there is weakness. Yes, there is weakness.
And abduction, adduction, all.
Yes, yes.
Okay, then I will examine the arms. First, I examine the arm, then the forearm. If there is any weakness
Forearm?
in flexion and extension.
Yes, there is partial weaknesses.
Yeah, okay. So is it mainly in flexion or in extension?
No need for more deep. It is only you take impression that there is weakness.
Just weakness. Okay. Any change in sensation at all?
The time is up already.
You can say no need.
Dr. Mahmoud, the time is up. I think yeah, 7 minutes now, 40 seconds.
No problem.
Okay, let's start the examiner question. You can start now.
So, Doctora, what is the finding in this case?
Okay, so what I find that the patient has inability to raise his eyebrow and close his eyes fully, and it seemed to be that this patient has the facial nerve. Sorry, 7
Yes, yes.
facial nerve palsy, and he has diplopia. It was positive, yeah.
No, diplopia is normal. No diplopia. I told you no diplopia.
Yeah. So the main thing that he has bilateral facial palsy, it looks to me, and
Yes.
he has weakness in the upper limbs.
Yes. If I give you 1 minute more, what you will examine? Or you told the examiner time finished, but I'd like to examine. What you wanted to examine?
For this gentleman, I will because bilateral facial palsy, maybe he has Guillain-Barré syndrome, and I want to examine his chest as well.
What you will examine in chest?
I will examine the upper, because one of the differential diagnoses I'm thinking about tuberculosis can be a cause of this. I will examine for apical.
What you will examine the lung?
Like what we call.
What else? Another than chest. What else? What you wanted to examine?
Okay. Apart from chest, I'm trying to memorize what things can cause bilateral. Okay.
I wanted
okay.
to. Okay,
I
until
examined
you,
for the third bilaterally. Nothing
okay.
in my mind, in fact.
You told me bilateral facial nerve palsy.
Yeah.
You decide this is upper motor neuron or lower motor neuron?
Bilateral, it will be lower motor.
Why lower motor?
Because it affects both.
Both what?
Bilaterally, I mean.
Bilateral what?
Okay. I just want to make it. It's lower motor neuron lesion in the. It will be in the nucleus, of the facial nerve.
Okay. Because eye is affected and mouth is affected, so whole face is affected, so it is lower motor neuron. Okay.
Yeah.
What is the differential diagnosis for this case? You told Guillain-Barré, and you are right. What other causes possibly to cause this bilateral lower?
Bilateral, it can be infectious, if we can say like neurological, like Guillain-Barré. Multiple sclerosis can be one of them. Sarcoidosis as well.
Less likely multiple sclerosis to affect. What else?
Rarely, but it can happen. Sarcoidosis can be as well. It can be infectious cause like Lyme disease, HIV. It can be Epstein-Barr virus infection.
Yes, apart from infection, enough for infection. What else? Yes, infection is enough. HIV, Lyme disease, Guillain-Barré.
And tuberculosis.
Sarcoidosis. No, tuberculosis is less likely to cause bilateral facial nerve. But what
tuberculosis
else?
Can be can cause. Okay. Anyway, SLE can cause autoimmune like SLE. And vasculitis as well. It can affect it. It can be idiopathic.
Idiopathic is caused by unilateral Bell's palsy. Okay, rarely to cause bilateral, but okay, acceptable. What else?
Diabetes.
No.
Diabetes, if it's affected the blood supply. I don't know how the procedure, but it can cause this.
You mean massive pontine stroke? This can cause. Okay.
Yeah.
Okay. Okay.
Neoplasm infiltration can cause as well.
Infiltration sarcoidosis. Okay.
Yeah.
Meningitis also, basilar meningitis can cause this cause. So, okay, doctor, for this differential diagnosis acceptable. But okay. What is the investigation for this case? To assure the diagnosis?
I will do first full neurological examination, complete full neurological examination.
What is the examination you wanted to do more apart from what you did?
Yeah. So if I'm thinking about Guillain-Barré, I will examine the lower limbs and as well for weakness, and examine the.
Wait. In the lower limb, what you will see as a picture of Guillain-Barré syndrome?
It will be more. I will see if there is any sensory loss. It will be lower motor neuron affection, so it will be flaccid paralysis.
Yes, flaccid paralysis, but sensation is intact. Only patient feels paresthesia, but the sensation is intact, but it is lower motor neuron character. So, hypotonia, reflexia.
Then I will do the peak expiratory flow.
Yes. But examination of the lung, not by stethoscope, or as you told me before.
Yeah, it
and
will be the peak
it will
expiratory
be
flow.
forced vital capacity, صح?
Yes.
Okay. And
Then I will do blood tests, CBC, ESR, and CRP. I will, because I'm thinking about vasculitis, I will do vasculitic screening as well. I will do Lyme serology, HIV investigation. I may go further for LP, for Guillain-Barré, and MRI brain as well, and brain stem, if I'm suspecting central cause of the disease.
Yes, and for sarcoidosis, what you will do to rule out?
I will do X-ray as first. I will do X-ray and I will sarcoidosis investigation. What is that? I'm not remember.
AC enzyme.
Yeah.
And serum calcium. Okay.
Yeah.
Yes. Okay. So if this patient is Guillain-Barré and confirmed by the investigation Guillain-Barré, so how you will manage?
If Guillain-Barré syndrome management, first I need this patient need to be managed in ITU because of possibility for the affection of the diaphragm, and the management plan will be will start with corticosteroids. I didn't remember why I forget everything about.
Not corticosteroid. Either one of both. يعني only two maneuvers. You will do one of them. Huh?
Yeah.
You remember? Plasmapheresis.
Immunoglobulins. I will give
Yes,
immunoglobulin or plasma exchange.
Yes. Plasmapheresis. Yes. Okay, doctor. Thank you, doctor.
Thank you.
Okay, well done, Dr. Mayada. Do you recommend Dr. Mahi, please?
Yes, Dr. Mayada said this patient has bilateral lower motor neuron affection of the facial nerve. And if she look to the face properly, no need to proceed for the first, second, third cranial nerve, 5 seconds, because from the picture, there is the patient cannot close the eyes properly and the forehead is flat, no wrinkles. And if you look properly to the nasolabial fold bilaterally, it looks paralyzed. So this patient has facial nerve palsy. So from looking to the face, you will go directly to the facial nerve to examine. So you will examine this patient by giving him orders. First order that you will tell him, look up. When you tell him look up, you take permission from the patient and from the examiner to put your hand in front above his head to avoid extension of the neck. Then he will look. At that time, you will see the wrinkles and the eyebrows go up. If yes or no. If no, so here his eye is affected. Other thing, you ask him, the patient, second order, close your eyes firmly. There are three possibilities here. Either he close firmly and the eyebrow go down and share in the closing of the eye, and you try to open it, yeah, you cannot open properly, so it is intact. The second possibility, only he closed the eyes, but still part of the eye is not covered by the eyelid, and at that time you try to open, it will open easily. The third and severe attack of the severe form of failure of closure, the eye turned up and you see only the conjunctiva and the eyelid did not cover the eye at all. So now by this you means is before you go to the mouth, you take impression this patient, his face is all are affected. But you will go down also and you give him order, please buff your cheeks. He cannot. Show me your teeth. He cannot open the mouth properly. So the face now is affected whole bilaterally. So now you take impression this patient has lower motor neuron affection bilaterally of the facial nerve. The second question you should think in, where is the lesion and why is the lesion? Where is the lesion? You should examine the sixth cranial nerve and the cerebellum, because the pathway of the facial nerve pass from the cerebellopontine angle. So you will examine by each shape. You found this patient has been or diplopia on looking to the lateral. So this patient has sixth cranial nerve intact or paralyzed. Then you will do only one test because no time from cerebellum. Finger nose test bilaterally from the upper limb, right and left, to know cerebellum is intact or no. Then you go down. You see in the facial canal in the ear, if there is any vesicles or anything, to exclude Ramsey-Hunt syndrome. Also, you look behind the ear on the mastoids for any scar, any discharge, because the facial nerve is passing from this area. Then look to in front of the ear at the parotid gland, there is any scar, and you try to palpate the parotid gland, there is any swelling, any hardness, in addition to the scar. To know where is the lesion, either from the pontine nucleus itself of the facial nerve or in the canal or in the behind, like this. So now you reach this, the diagnosis is bilateral facial nerve palsy.
Can you repeat
You put
again, Dr. Muhi, where is the region? How you will examine?
you know, the facial nerve, it arises from the bones, brainstem
Yes,
bones.
cerebropontine. Yeah.
Yes. So possibility of massive or not massive. If bilateral, it means massive, a stroke of the bones. So this is one of the possibility, but you cannot do this but you look only to the ear and in front of the ear and behind the ear, because maybe this patient has mastoid abscess, mastoid discharge surgery before and the affection the cranial nerve, Stevens cranial nerve. And it also pass in front of the parotid gland, so maybe scar before, and the doctor cut the nerve during the surgery of parotid gland or taking a biopsy or anything like that. I mean, the pathway. Also, there is named cerebellopontine angle tumors, meningioma, and it can cause compression of the facial nerve. But how I can say this patient has cerebellopontine angle tumor if the sixth cranial nerve affected and cerebellum affected? So you will examine for each shape and
غير فيه أعشاب صينية.
and cerebellum. What, Doctor, what you say?
I guess by mistake. Continue, Dr.
Yes. So now you reach to the diagnosis of Guillain-Barré syndrome or sarcoid or massive pontine stroke. There are other differentials such as basilar meningitis and traumatic fracture of the base of the skull. This is causes, but the most probable diagnosis is Guillain-Barré syndrome, because the patient looks young and this acutely developed. You will examine the, no need to do many things like Dr. Mayeda did. You go to the lower limb and check the reflexes, areflexia, hypotonia. So mostly this patient has ascending paralysis of Guillain-Barré syndrome. Okay, this is the case. Yeah.
Okay, thank you, Dr. Wahi.
Welcome.
But
welcome.
I will just add to your differential Bell's palsy. It's the most common high yield and common cause of bilateral facial palsy.
Okay, so
Are you agree? On the top of all the causes, Bell's palsy. Agree for that?
هو اللي
دي
مكتوب قدامي
bilateral.
بالز بولسي هو
Yeah, it comes as
Palsy
bilateral.
unilateral, yeah.
Yes, it's
80%.
unilateral, but it might be bilateral.
It can
come.
rarely, yeah.
It might happen. And Lyme disease as well. So as Dr. Mayada did and asked for history, infectious causes. And the causes Dr. Muhi mentioned, yes, it's there. But we are talking about the most common, then the less common.
So
This
it's
is what I know. Okay, go.
Question for Dr. Mohi. What's the cause of
80%
weakness in
80%
upper limb, Dr. Mohi? What's the cause of weakness?
ايه
What's the cause of weakness in upper limb?
Guillain-Barré.
Guillain-Barré. He want to say this is a Guillain-Barré syndrome.
but not a variant of Guillain-Barré, because Guillain-Barré will be like ascending, so he will be have failure in respiratory and like that if it is reached to be facial. So if it is ophthalmoplegia and facial, maybe it is Miller-Fisher. So we will search for ataxia, reflexia, the triad of Miller-Fisher, or what? Or no, not the.
I agree with Dr. Aisha. If we suspect something, a typical presentation of Guillain-Barré which is not ascending, we have to think about this variant of Guillain-Barré, which is Miller-Fisher.
Yes,
I
and
agree.
also other lower motor myasthenia gravis syndrome and facioscapulohumeral.
I suspect this is from the picture. Yes,
Yes,
myasthenia.
this is very, very common to come in to have the girdle also, the facioscapulohumeral myotonia is our myopathy. This kind of myopathy affecting my ptosis and make weakness in the upper limb, and it works usually only lower motor and with impact sensation. And the differential diagnosis, Miller-Fisher syndrome, which is very uncommon. Miller-Fisher syndrome to a variant of Guillain-Barré syndrome. Usually, this patient will have respiratory, and this is very important, as this question would be the question of pulse. If the patient has Guillain-Barré syndrome, he will ask about respiration and the volume of respiration. Then what we will do, you have to answer ABCD. You have to say ABCD, because this patient is very critical, needs to ICU. If according to the volume of respiration, the volume expiratory volume 1. هو ده يعني ده الموست امبورتنت كويشن في الحته دي، سواء في الماسونيا جرافوس او في الجولان-باري syndrome. دايما هيسال في الريسبيراتوري symptom affection when the patient may need ABCD.
I agree with you, Dr. Good. I appreciate it really, but now he's talking about facial nerve palsy as a facial nerve. What you mentioned is neuromuscular junction, so it's another differential. If he asks what the cause of ptosis, you can say these causes. But he's speaking about facial nerve as facial nerve, right? Agree with that or no? I'm also discussing with you.
Yes, but ptosis in facial nerve, is the facial nerve make ptosis? يعني what the differential diagnosis of ptosis is I think this is not ptosis. This is paralysis.
Yes.
Yes.
Because I think
so
the
we
facial,
cannot...
he can't close tightly.
Okay.
But
so we
he
can't...
can, but you know that in the management of facial, we giving like something to close the eye because he can't close.
Exactly.
But the ptosis is not really a observed sign in the facial, I think. It is in Horner syndrome, yes.
Yes, ptosis is one of the manifestation of Horner syndrome. But paralysis, as you mentioned, Dr. Muhi, I think it would be something other than facial nerve palsy.
Because it is bilateral, it is really confusing us. Yes. Maybe if it's unilateral, we can compare like.
And also for myasthenia gravis, it can be presented as paralysis.
Yes, and the facioscapulohumeral also have the same look. Even the myotonia cases in my exam have the same look.
Yeah, myotonia will be like this. But I guess this is ptosis, but both of you saying it's not ptosis, it's something like paralysis. I don't know.
Yeah. Three muscles are affected in the facial nerve palsy: frontalis muscle, orbicularis muscle, and the
Yes,
buccinator.
exactly.
But
Those muscles are
the orbicularis muscle for closure, not
paralyzed.
for opening.
Paralyzed.
Yeah, to close tightly.
Yes, because in the facial you will find the patient open the eye. I think he can
Good, you
open, I
mean?
think,
Yeah,
the eye.
yeah,
Just he can't raise the eyebrow up.
yeah. It's confusing case, Dr. Mahi. So we can summarize this case. So this patient is unable to raise his eyebrows, right? Plus, he cannot do blowing. So these are the facial muscles supplied by the seventh or facial nerve pulse, by facial nerve. But regarding the ptosis, will
There
be
is no
there.
ptosis. There is no ptosis at all.
So what is
But,
this?
no ptosis. This patient, the patient in the photo, the doctor asked her to close her eyes. She cannot close. So this is
Okay.
she tried to obey the
Yeah, yeah.
order,
This
but
is
she
while
cannot.
she's trying to tightly close the eye.
But she cannot. This is order
Okay.
from doctor to
Yeah, I
the
got it now. I thought it's ptosis. That's why I was confused. Also, Dr. Gouda gave us differential for ptosis. Right, Dr. Gouda?
Yes, there's no ptosis. This patient cannot close her eye.
Yeah, so this is a different topic, totally different. Then we can mention the investigation as Dr. Muhi said. But I have advice, Dr. Muhi. Whenever you have facial manifestation, it's not a matter of examining facial only. You have to examine from the first till the 12, right? Because you said, no,
60
it's...
minutes, 60 minutes, and the order look to the face and examine accordingly.
No,
So
no,
he should
I
take the intuition, yes.
yeah, I
Okay.
agree with this, but it's very tough to give a question like this and wait to assess the facial nerve also only. I guess this is but it might be also some examiner, some centers toxic like this. So they wait
I,
for...
I see some orders also examine the eye neurologically, examine the face neurologically, like this in exam. In my exam first trial, they asked me examine cranial nerves, and the problem it was in the visual field only.
In our center also the round after us, they bring cranial nerves, examine cranial nerves, and most of the candidates said that it's no any abnormality.
Like me. Yeah,
But some of them mention that some fatigability or something like myasthenia or something.
I will tell
Let us
you my
let us
case.
يعني review بقى الماثينيا gravis signs يعني what you would expect in patient with myasthenia gravis to physically يعني what you will do if this patient has suspected myasthenia gravis.
I think they suspect from the snare or from when you examine the mouse.
Yes.
There is power, but you will suspect there is some weakness, so you will do the fatigability test.
Fatigability, open and close your eyes and
But
move your
most
hands.
of the candidates didn't do. Just
What is the clue? What is the clue, Dr. Aisha, to know that this is myasthenia gravis? Because if you catch the disease early, you can examine properly.
really, the doctor that said to me this case, he said I really start at normal cranial, and when I examine, the faces of the patient look like myasthenic, like a small mouse or something like flaccid mouse. And when he checked the power of the cheek, when you checking the seven nerve like clench your teeth and try not push your teeth down. Like also the third cranial, the trigeminal, the bar of trigeminal. He suspected that is the bar not fully, even it is not paralyzed, but it's not fully. So he did the fatigability test at last, and
Yes,
he said,
This is
counting
ilham.
counting numbers, moving the hand and to open and close your eyes. I think repetitive is
This
some
is
tests like this. Like,
yeah, it's like this, but how to guess this is a myasthenia? This is ilham from Allah. Do this to have
yes,
this.
Yeah.
because
Really,
it is a case
sometimes you
of
will do
Dr. Talat,
examination
really, and
and
he said it is all the candidates. They said this is normal cranial nerve examination,
uh-huh.
but and he was suspecting in himself when all they said like that.
هو
He said,
إلهام فعلا زي ما دكتور باسم قال.
Yes,
uh,
exactly.
وان هو اصلا if he did not catch the disease he will not do the
Exactly. What
fatigability.
I will do, why I will do fatigability.
Mm.
Myasthenia
Exactly.
Davis as a long clinical better than short because you will
Yes.
know from the history, the fatigability, the timing, but to guess it
Fluctuation
from
of symptoms.
snare or weakness after counting, it's not something to be applicable in second minute. And to do the proximal myopathy in the hand, proximal and ocular.
no, he did also only the because no time. He did only in the last minute the fatigability test in the eye.
Mm.
and the
And,
same.
and
And
for,
and my
for
my,
you,
my
يا
opinion
دكتورة عائشة, for you, when you talked to me us about mytonica dystrophica, how you catch the disease and what was the order for you to examine
And
the
No,
the grip.
just
specific?
I examine neurological because this is neurological. I examine the upper limb, and when I come to examine the grip by my two finger, I said to him it is okay, and he's still not releasing my finger.
Mm.
When I
Leave
check
my
in the
hand.
other hand, he did the same. I suspect that this is the
Mm.
only. It is also Ilham.
yeah.
Like, but
Exactly. Yeah.
I suspect it is fascioscapular, like because he is very like he had very thin, no muscles at all in arms.
Yeah.
You feel that he is really myopathy. And because I didn't see before myotonia, so I just suspect it is myopathy, like fascioscapular, like that. When he
What
did
is
this, I realized it is myotonia.
what was the order to you? Examine what our limb or
Just
face?
if
What
no,
you
it
what
is
did
long
you
Examine
case.
Okay.
It is long,
a
Long.
prop.
long, long
long
Okay.
clinical.
Long,
weakness, long.
yeah. Long is supposed to know also from the history, but in the short, it's very difficult
But
to catch it.
how you will
It
know from
come to
history, Dr. Bas?
it come to my friend wallahi in session 3. It come
Mm.
to
Myotonia? Maybe from
my
the toes is the fascious, you can know.
myasthenia dystrophica is.
I
What is
think
the specific feature? It is the slow relaxation because this is typical also with fascioscapular or with myasthenic. These
Mm.
faces, I think, typical for another cases.
in any case, it poses in the exam you should put in the differential diagnosis. Myotonia gravis, myotonia dystrophica, and Horner syndrome,
Fascioscapular,
and
fascioscapular.
then angiofascial scapulohumeral, and this and the other autoimmune diseases.
Third cranial nerve,
My,
third cranial nerve. Yes.
yes, cervical nerve palsy and other myopathy, or myositis, or dermatomyositis, autoimmune, and the other myopathy, that this cases, I don't know, girdle, limb girdle syndromes, and all myopathic this, and they have to
Limb
do the
girdle characteristic not affecting the face at all.
But wide range يا دكتور جودة والله wide range of the differential يعني how I can say all
you
this.
should start by muscle. You should start the muscle enzymes. You should aldolase and creatinine kinase,
I think
and then
genetic as well.
and yes, genetic counseling. This patient is autosomal dominant, and this is one of the questions we have been asked. What is the percentage of to pass this disease to his children? I said
Yeah, autosomal
50%.
dominant. Yes.
Autosomal dominant should 50% for every child has a opportunity to have myotonia dystrophica, and this with anticipacity, because something called anticipacity. This means he can come earlier in his children.
Anticipation, yeah.
Yes, with anticipation. And we about also how long is the recurrence of this triplet or the repetation of this of the gene, the problem of this gene, and about also we have to discuss about the muscle biopsy and
Muscle
genetic testing,
biopsies, exactly.
genetic testing, muscle biopsy, and the nerve conduction study, neurophysiological study, and also the autoimmune markers for CRP, ESR. This is basic, very important. And of course, anti-nuclear antibody and the other diseases that dermatomyositis. You have to mention the
Possibility?
mark.
CKMB,
Yes.
yes. CKMB.
Yes. Yes. Exactly. For because he will ask about this, this may be affecting the dermatomyositis, and the other one, the polymyositis, and
the acquired causes, I think. Acquired cause of myopathy, or it's not?
Yes, and also of course the anti-acetylcholine and esterase antibody, and the other one is Lambert Eaton-Lambert syndrome, the DUSC, the anti-calcium, the other autoantibody for calcium for Eaton-Lambert syndrome. If the patient has paraneoplastic syndrome, this is very important, especially the lung cancer. So this is one of the differential diagnoses. This is the long list of differential diagnoses for lower motor affection of the face and the upper limb.
You know, the case came to me in the examine this cranial nerve, this patient cranial nerve, and he was surrogate. I examine everything, station, يعني cranial nerve 2 and 3 and until I reach 9. I found patient is okay, and patient is laughing and he's joking with each other. So the examiner told me, what is the problem? يعني, present your finding. I told him this patient is normal. He laughed. He laughed much and he said, normal at all, nothing. I told him I did not find any problem in this patient. So he told me, what about visual field? I told him, yes. When I examining visual field, I take impression, patient has inferior quadrant anomaly. I said, yes, this is the abnormality. What is the differential diagnosis? I told him differential diagnosis. What is the investigation? What's the treatment? I answer all the. At the end, I found in feedback, he gave me only 10 from 20.
Yes, because he give you a clue.
Yes.
Once he give you the clue, he will minus you. And 10 is good mark, wallahi. If... Sorry? Okay, sorry. I think Dr. Moha, yes, once you don't know the diagnosis and he help you, at least you will get the half mark.
بس انا لقيت العيان عمال يهزر كده وما عندوش حاجه. والله وبعدين افتكرت بقى وانا بساله do you see my finger? He said no. قال لا خلاص الفنجر خلاص وصل الميد لاين، بس ما خدتش بالي ان انا فكرت ان هو
No, be serious in the exam. Yes, I believe even the examiner don't smile or joke with him. Some of them, they have different personality. Even you are doing well in the exam, in the performance, he might minus you for this behavior. I don't know why they are doing that, but it's okay. Just avoid this with them. Okay. Any question, Dr. Mayada, because you are the one did the case.
No, okay. Okay, nice discussion.
What is the case, Dr. Mayada, for me?
Just a minute. So this, I will say the case, or do you want me to send the case?
No, it's supposed to be as a...
just I will say, okay. 55 years old gentleman, can you examine his respiratory system?
Okay. Here you go, Dr. Mahi.
I will go inside and then I greeting the examiners and greeting the patient. Okay. Dr. Ismail, I was asked to examine you. Is that okay with you?
Yes.
Do you have been anywhere?
No.
You will be gentle while examination, but if you feel pain, please let me know, okay?
Okay.
I will go down 2 steps and I will take alcohol for my hand to wash my hand and see surrounding any cylinder of oxygen, any mask for
No.
respirator. Is there any one of these?
No.
Any cannula connected, any oxygen face mask on the patient?
There is a cannula, but there is no oxygen connected.
Okay. Then I will look to him. He's sitting in 45 degree and he's comfortable or tachypneic.
Comfortable.
Okay. Then I will ask the patient, please, can you extend your arm for me?
Okay.
Then I will see, is there any tremors? Fine tremors?
Yes.
There is fine tremor. Okay. Can you extend your wrist? Okay. There is any flabby tremors?
No flapping.
Okay. There is any nicotine staining in between fingers?
Yes.
There. Okay. Any clubbing?
Yes.
Any pulmonary erythema?
Yeah, there is.
Okay. Then I will put my hand on the pulse and I will calculate also the respiratory rate. Okay. In 15 seconds, how many are respiratory rate? Okay.
89 for the pulse, and the respiratory rate is around 20.
21. Okay. Okay. Then I will go to the face. I will see any jaundice, any pallor. Okay.
No.
Okay. I will go down to the GVB. Any raise of GVB?
No.
5 degree. I will expose the chest. Okay. Down. I will go back to the lower limb and I will see if there is any edema.
No lower limb edema.
Okay, at that time, at lower limb, I will see the chest. I ask the patient to take deep breath. Any limitations of the expansion of the right or left lung?
Generally reduced, but equally expand.
Okay. I will ask him to cough. What about the cough, the right or was there
Yeah, it is wet cough.
Wet cough, okay. Then I will come back to the patient. I will ask him to sit down, okay? I will check the trachea. It is central or shifted?
Trachea central.
Okay. I will check the crico sternal notch space, 3 fingers or lower or less?
Less.
Okay. Tracheal tuck by 1 finger horizontal. I ask the patient to take deep breath. There is?
Yeah.
Tracheal tuck is present?
Positive, yeah.
I will examine back of the chest first. I will put my hands and check the expansion above, in the middle, and the lower. Take deep breath in and out. Okay. Expansion is limited.
Yeah, limited.
Okay. Then I will do percussion. There is any resonance or dullness or?
Yeah, hyperresonant. It's not hyperresonant, it's resonant, yeah.
Okay. Then I will auscultate in the back bilaterally and compare. Is there any wheeze?
Yes.
There is wheeze
bilateral scattered wheeze.
Okay. And the expiration is prolonged?
Yeah.
There is crackles or no?
Scattered crackles.
Okay. I ask him to cough. And is there the character of the crackles?
Yeah, change.
It change. Okay. It is coarse crackle?
Ronchi, like the scattered ronchi, more than crepitation, not chorus.
Coarse or fine crackles?
It's fine.
Fine, okay. Okay, then I will ask the patient again. I will repeat auscultation and I will ask to say 99 or 44 in Arabic.
1 minute left.
Okay. Is there any change in the bronchial breathing or anything?
What you want to hear? Is it high? What do you want to hear?
99. I will ask him to 99. Exaggerated breath sound or decrease or normal, no change?
Yeah, exaggerated.
Okay. I will go in front and I will do expansion also. Okay. It will be limited. So I will do percussion in the axillary bilaterally. Resonant?
Yeah, hyperresonant.
Okay. Then I will do auscultation. Is there any wheeze, any crackles?
Yeah, there is.
Axilla and the bilateral of the side of the lung. Okay.
Yeah.
Okay. I will offer to examine lymph nodes also. There is what?
Yeah, it's okay. Don't examine.
Wheeze and the crackles?
Yeah, there is generalized wheeze and crackles all over the chest.
This crackles is fine or coarse crackles?
Fine crackles.
And you not change it with respiration?
And change with respiration.
Okay.
Okay,
I
time
will,
is up. You want to add some examination, doctor?
Yes, only B2 and heave and apex.
Okay, perfect.
Okay, good. What do you want to add?
Only to see if there is pulmonary hypertension or no, but as long as no GVB raised, so no pulmonary hypertension. Okay. And apex on the left side, huh?
Yes.
Okay.
Still, you may have cor pulmonale, but without congestion.
Yes,
Maybe JVB is not that raised, but still you need to examine the second heart sound, and you need to see if there is parasternal heave.
Yes. It will be mild, yeah, pulmonary hypertension.
Do you want... Okay, present your case.
This 55 years old gentleman, he is comfortable at rest. There is cannula connected. Respiratory rate is 21. There is fine tremors, no flabby tremors. There is pulmonary erythema. There is clubbing and nicotine staining around fingers. There is limited expansion of the lungs bilaterally. There is generalized wheeze and fine inspiratory crackles and the prolonged expiration.
Okay, so what is your differential diagnosis?
Differential diagnosis of this patient is obstructive lung disease with possibly fibrosis.
Okay, and what investigation you're gonna do?
There is general investigation and specific investigation and the bedside investigation. Bedside, I will start with ABG situation. Okay.
What do you suspect in the ABG?
I will suspect CO2 retention, respiratory acidosis, possibly compensated with metabolic alkalosis. Okay.
Metabolic alkalosis.
Alkalosis, yes, يعني increase of bicarb.
Okay, so you suspect that this patient has compensated.
Yes,
compensated.
Respiratory acidosis, yes. Respiratory acidosis, compensated respiratory acidosis. Okay.
Okay. Then, what is the most important predictor of COPD exacerbation?
Predictors?
Yes.
What is the most important predictors?
Yeah.
CO2 retention. Yes, rise of CO2.
Okay, so the most predictor, the history of exacerbation and hospital admission. That means this patient has a lot of COPD exacerbation. Okay, so the history of previous admissions
You
and
mean
degree of the limitation.
You mean the cause of recurrent admission and the exacerbation?
Yeah, the severity. I mean, what indicate that this patient COPD is not well controlled and there is a lot of exacerbation. Severity, predictor of severity. Okay.
Yes, obstructive function of the spirometry.
Mm-hmm.
Spirometry, obstructive function in low, peak expiratory volume in 1 second by forced expiratory volume, it will be below 70. As long as it is, يعني the lower the more bad COPD.
Okay. So what is the staging of symptom exacerbation of COPD? What do you know about staging of COPD?
Yes, there is stages, yes. There are 4 stages, but I cannot remember them now.
Okay.
4 stages.
What is the complication? What is the comorbidities you suspect for a patient have COPD?
What again this question?
Comorbidities and complication of
Complications
of COPD. Yeah.
respiratory failure. Respiratory failure.
Mm-hmm.
This complication, recurrent infection,
Mm-hmm.
core pulmonale also can be pulmonary hypertension.
Yep. Yes. Polycythemia.
Polycythemia also, yes, and this
Yeah. Core pulmonale, and ultimately it can cause cardiovascular disease and heart failure.
Yes.
Muscle wasting.
Muscle wasting. Yes.
From the treatment itself, osteoporosis can be secondary to the medication as well.
Corticosteroid, yes.
Lung cancer. All
Lung
this.
cancer.
Yeah. How you will manage this patient?
According to the stage, the 4 stages you see,
Mm-hmm.
according to the EBG also, and the investigations.
What you will do if this patient comes to the hospital?
I will do X-ray and possible
Mm-hmm.
also high resolution CT. If there is any emphysema, any bully, after pharmacological management, if there is a name as lung reduction surgery to remove this loop or this
Why
bully.
you come from the end?
Not from the end, because I
Yes,
wanted
it comes from there. When I said managing the patient, that
we will
means
admit this patient and we will treat the infection and correct the bronchospasm, and this is baseline management for every day. Then for recurrent admission and the patient not improving, so we will thinking outside the ordinary. So we'll do high resolution CT if there is any, as I told you, bully or damage to one lobe and increase hyperinflation of the lungs. So lung reduction surgery can be, and also can be lung transplantation, even unilaterally if it is dry, like this.
okay. Okay. So what is the best way to deliver oxygen in acute COPD exacerbation, and why?
Best way of delivering oxygen?
Yes.
If this patient has respiratory failure or impending respiratory failure with CO2 retention, so by BAP is
No, I
the
didn't. Normally, the patient is not type 2 respiratory failure, not needing NIV. What is the way you deliver oxygen to this patient? What is the best way?
so you mean mask with reservoir?
You will give him mask with reservoir?
I don't know. I don't know. You mean this?
Yes, I mean this tool. Yes, I mean these tools of delivering oxygen. Which the best way to deliver oxygen for this patient?
Our target in COPD to make this oxygen, it is from 92 to 88, not correcting oxygen more, because it is the hypoxemia. It is
Okay.
only for
Which device you will use?
nasal cannula, 2 liter. We usually use this.
Okay. Okay. Thank you. No more questions.
Wrong, huh?
Well done, Dr. Mayada. As examiner, really, it's a very serious examiner.
The examiner فظيع والله.
Yes. And the way of asking the question, like very tough examiner. Not tough, she's serious examiner, not tough examiner. But she's
يعني عايز استشاري صدري يجاوب على الأسئلة دي.
no. By the way,
Time.
all question part 2. I mean, this Venturi mask part 2, right? Right, Dr. Mayada?
Yeah.
Venturi mask is one of the question in part 2. I remember till now. Venturi mask is the best way to deliver oxygen in COPD patient. And the target, as you said, but the way to deliver is Venturi mask. It's a mask you can adjust the flow and the oxygen accurately. So you can target without retaining CO2.
Because this patients, COPD patients, they are very sensitive to oxygen. Very sensitive to oxygen. That's why you need to use Venturi mask.
Exactly. They are dependent on the hypoxia as a driver.
Yeah.
If you give them oxygen, the patient will be sleepy and he will go into coma, CO2 narcosis and coma. That's why it's very sensitive to oxygen. You have to deliver oxygen in accurate measurements and amount, yes. But in general, Dr. Mahi did well. We didn't hear the comment, right, Dr. Mayada? You can comment. Sorry, I interrupted you. Yeah, please.
Yeah, I think the management, you did the examination very nicely and you go with all the steps. But this patient has clopping. Normally, COPD patient didn't have clopping.
Yes.
But when you have a clopping with a patient with COPD, you suspect cancer.
Yes.
So
or bronchiectasis. Or
bronchiectasis, yeah.
Yes. So I asked you, and I asked you 2 times. This cretaceous is coarse or fine? You told me fine.
Yeah, it's not bronchiectasis. It's not bronchiectasis.
Yes.
But you need to think about cancer.
But also fibrosis can has club. Yani if the patient has bilateral crevitations and it is fine, so possibly this
idiopathic type only. The idiopathic type only. Not every fibrosis.
But as in fact, any patient with COPD, you will find these crackles. You'll never find his chest is clear.
Yeah. You might have
this is the normal of them.
Yeah, they might have infection on top of COPD.
Yeah. And you need to examine the base of the lung to rule out there is no core pulmonale as well.
Exactly, yes.
The other thing that, the management plan. You need to start with our normal steps. Management plan of this patient. You will start with bedside investigation, ABG and ECG, both of them. And then you go for blood test, looking for any serious, if there is any infection and eosinophil count, because in the management plan, you want to see if this patient will respond to, how he will respond to hydrocortisone and everything. And then you will, neutrophil count for infection as well. We said that. Then we'll go further to chest X-ray to roll out infection as a cause of exacerbation. And then after that, if we are suspecting whatever, we'll go for deep investigation. If we suspect cor pulmonale, we'll go for echo. If we are suspecting cancer, we go for CT scan, and then we'll go like this. One question I want to ask as well, but I didn't ask it. What is the indication of long-term oxygen therapy?
Yes. If pH of the patient is below 7.5 and patient stop smoking, or it is 7.5.
Wait, it's not pH, Dr. Mahi.
It is what?
Revise your answer.
What is the seven? This I forget all that.
PO2.
Yeah, BA2.
Yeah,
Yes.
yeah.
BA2. Yes. It is if below 7 alone, or 7.5 with one of the following: cor
Still the
pulmonale.
number. Wait,
Number.
you cannot remember the number. Yeah, 7 point. Correct the number. 7 point.
7.3.
Yes, now it is. Go ahead.
7.3 and one of the following اللي هو polycythemia or cor pulmonale edema lower limb يعني. What's the third one? They are three: polycythemia or
Pulmonary hypertension.
Pulmonary hypertension.
Pulmonary hypertension. What is the third one?
Polycythemia.
The patient stopped smoking. You said that.
No, this is as a rule before starting this oxygen. But there is 3 criteria: edema or cor pulmonale and polycythemia. And there is one more. I don't.
Nocturnal hypoxemia.
Nocturnal hypoxemia.
Yeah. So,
but before wait, Dr. Noel, before moving forward, the numbers is not as Dr. Muhi mentioned. So remember, Dr. Muhi, either less than 7.3 only. This is indication, or from 7.3 to 8 with one of this criteria. PO2, if less than 7.3, this is very indicative for oxygen therapy, long-term oxygen therapy, 16 hours daily. But if you have 7.3 till 8, from 7.3 to 8 as PO2, you have to find 3 criteria, as we mentioned. And you have to do these 2 ABGs and 2 weeks apart without exacerbation. Okay, this is the criteria when to start long-term oxygen therapy. It's very important, by the way, in the exam. They might ask you this question. Okay. Okay, continue, Dr. Mayan.
Then we are in the management plan. We did the investigation, the bedside investigation, and the lab investigation. Then we go to the chest X-ray, and if there is we are suspecting complication, what investigation we'll do. Then we need how to treat. The treatment will be treatment of exacerbation. There is different way, and if the patient is stable, what is the maintenance like treatment? Vaccination. And they are very important in that counseling. The patient teach him about the disease and inhaler technique and stop smoking. You have stain in his fingers. You need to know if he's still smoking to counsel the patient about it, because it's a very important thing. And then the pulmonary rehab.
Rehabilitation program, yes.
Perfect, Dr. Mayada. And the acute exacerbation? Continue.
Yeah, in case of acute exacerbation, we need to see if the patient needs hospital admission or no. Sometimes we can treat acute exacerbation at home. In the hospital, we need to see if it is infective exacerbation or non-infective exacerbation, because antibiotic is not always we give antibiotic for COPD patient. If it is infective, we treat with antibiotic, and which antibiotic? This is the question. Which antibiotic normally we give for patient with acute exacerbation of COPD? In other way, which bacteria more suspected in a patient with COPD?
Dr. Mohi, yeah, give us the prevalence. What the common organism usually infected the COPD patient?
three organisms: Haemophilus influenzae,
Perfect.
the one number one.
Yes. Second. The second is the most common all over as a pneumonia.
Streptococcus pneumoniae.
Yes. Exactly. Yes, this is the one. The third.
Neisseria meningitis.
No, 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 no. Why? Why you went to Neisseria and meningitis? You want to give him meningitis plus COPD?
I cannot remember the third one.
Is it staph? I think. Dr. Mayada also can correct me. What I remember, staph aureus, Haemophilus influenza, streptococcal, and no. Okay. Dr. Hens.
Moralis.
Yeah. More. Yeah.
Yeah, the name. Yeah, but the most one is Haemophilus influenzae.
Yeah. Yes. As we mentioned. Yes. Exactly.
Yeah.
Okay.
Okay, so normally we give like
Varicella
clarithromycin and
catarrhalis. Yeah. Okay.
these things. In the acute exacerbation, we will symptomatic management. It will be with bronchodilators and ipratropium bromide, bronchodilator, both of them.
Yeah. The bronchodilators. No.
Bronchodilators and
Yeah.
antibiotic acute exacerbation with
And
infectious and if there is mucus, if there is a lot of mucus production, we can give mucolytic.
mucolytic
And chest, if the patient needs chest physio to
and
help him, and saline
and
nips and hydrocortisone. If
yes.
yeah,
Finally.
we
Not
will give
hydrocortisone.
it's cortisone.
Yeah.
Cortisol,
Methylprednisolone. Yes. Methylprednisolone.
yeah, with in that one. Okay.
Okay. Yeah.
The
Yes.
acute
Any
exacerbation.
role of magnesium oxide in this patient?
No, it not
Yeah.
work unless we
Exactly.
have mixed with asthma.
Yes. Reversibility test.
Yeah.
After doing the reversibility test, if you suspect there is asthma features.
Mm.
Otherwise, no role of magnesium oxide. Magnesium, sorry, what magnesium oxide? Magnesium sulfate. Sorry.
Mm.
دول
Okay.
سحر والله في الحالات دي. حالات البرونكوسبازم بيجيب نتائج هايلة.
Yeah. 2 grams within 30 minutes, it gives the effect after failure of all lines. But steroid, it's a must as a high dose, 1 milligram per kg. Stat dose, then a divided dose. It's not necessary to mention, but corticosteroid is one of the management plan you have to mention. I think anything else, Dr. Mayada, you want to add?
I think then the only thing I'm just trying to remind
Recall.
myself. That's why I'm asking
Yeah.
all this question.
It's okay. Yeah.
Okay, then the treatment, step of the treatment.
Yeah. Perfect. Say it.
Yeah, so we'll start first with the short or long-acting bronchodilator, and then then we go to group B. It's either LAMA or LABA. Group C, I think LAMA, and then group D will be combination therapy. We need
Okay.
ICS
I will
either.
Let's arrange in simple way. Okay.
Mm-hmm.
You will do reversibility test first.
Yeah.
If it is positive, you will start this patient on X, inhaled corticosteroid, X, ACS, ICS, inhaled corticosteroid plus bronchodilator.
Yeah.
If no reversibility, you will start the patient on first
LAMA.
SABA, LAMA
Or
and
LABA.
LABA. Yes, long-acting muscarinic antagonist or long-acting beta agonist. If the patient is not responding, you can add also short-acting. Or the opposite. Maybe I make the opposite. So you start with short. Then, if no response, you can add long. Someone can correct me.
It will be all of them, like
Yes.
long acting
Anyway,
and
you will start all of them. Yes.
yeah,
The first
ICS
step
and
short or long alone, bronchodilated alone.
Yeah.
And the second
Short.
step it
Short.
is long. لا بقول لما.
Okay. So
Short
we'll
or
start
long.
short first. Saba or Sama. Then,
Yes.
if no
And the
response,
long
we'll add
also
long.
in the yeah. The long is the second step. Second step no short.
No short. Yes, you'll add the L long. Yeah. Okay.
Yes.
Okay.
And third lemma only force all with ICS. And there is the new modality. This is roflumast. This is phosphodiesterase inhibitor.
It's written, the written part, yes. But I don't think they will go deep to the pharmacological. It's 4 minutes in the short station, but at least read it once.
you may find it in the long case just to make sure that you see the
Yes, it
important.
might be in the long and they might go deep with you. But
And
again,
there
there
is
is,
something also in COPD, they now like to say to investigate for alpha-1 antitrypsin level in
yes,
COPD patient.
as a cause of, there is a question also, what are the causes of COPD, Dr. Mayada?
Yes.
Yeah. First, smoking history
Yes,
can be alpha antitrypsin.
yes.
Also,
One more. What, Dr. Mahi?
Occupational.
Yes, this is
Yes.
this is the toxin or the occupation.
Yeah.
Cadmium or whatever the exposure. So it's there. I think the coal worker also can be. It's 2C.
Full worker, yes.
Yeah, this is the most common question in COPD. I think Dr. Mayada, mashallah, covered the whole topic. And Dr. Muhi also did well,
The
but
difference, you mentioned difference between the asthma and COPD on spirometry.
yeah, perfect. Good question. Also one of the high yield questions. Dr. Muhi or Dr. Mayada, what the difference between asthma and COPD?
The reversibility test will be
Yes.
20% in asthma.
Okay.
And in COPD, less, not positive.
So you will say only more than 20%. This is asthma.
Asthma.
And
Less.
this is
20% or there is another number. 200
and
ml.
decrease the
Right?
carbon monoxide.
What carbon monoxide? Delivery?
This is diffusion. Diffusion, yeah.
Diffusion?
There's also some new tests, I think,
Nitric
to
oxide.
differentiate.
Decrease, DLCO.
Yeah.
No. This is a nitrobroside.
This new,
Nitrobroside. Some new test, nitrobroside, I think.
Okay. What it will be? Nitrobroside.
I didn't hear about nitrobroside really. Who read about it?
كان أحمد ماهر اللي هنا في الكورس.
Sorry? Nitrobroside? I remember pheno, nitric oxide, but I don't know about nitrobroside. Anyone has information about it, he can share with us now or later on.
Later, inshallah. Something nitric.
Nitric oxide, not nitrobroside. Nitric oxide. Pheno, right?
Pheno, yes.
Yeah, it's nitric oxide, not broside. Nitric oxide, okay?
Okay.
This is in asthma also. It will improve the ventilation or the diffusion. But in COPD, no role or it hasn't any effect. One more also, spirometer, diurnal variation. You can do it. Plus for occupational asthma, you can do also the spirometer, right? Anything else, Dr. Aisha, we missed this topic?
There's a comparison between the patient with asthma and COPD. Usually, this patient has history. This patient has childhood history. This patient
Allergy
has,
and atopy, yeah.
yes. Yes, about asthma, and it's as you said, it's seasonal and intermittent. In between, it's completely normal, not like COPD. And usually
The
the
wheezes
age, this
also.
is the wheezes, and the age, this usually the young age, and this usually in old age, the COPD, nitric oxide, and the reversibility test. And about the question also, this is important. Come to my exam. The patient has COPD. In my chest case, I got 19 out of 20 in my chest case. Because of this question, if the patient has clubbing, and what's the cause of clubbing? Yes, it's the most important to exclude malignancy in a patient with COPD because they is a smoker and that is risk factor for small cell cancer, or that's squamous cell cancer because of the smoking. And also the repeated infection, COPD exacerbation may have some hidden bronchiectasis, and this is a source of any suppurative, what is it, empyema or lung abscess or bronchiectasis. This is another reason. The last thing to have idiopathic intrapulmonary fibrosis as a cause of clubbing, and the question come like, what is the degree of clubbing? He wanted to say this patient has the fourth grade low osteoarthropathy, because lung cancer may have osteoarthropathy. You have the rest hypertrophic changes.
Hypertrophy, HOPA. Hypertrophic osteoarthropathy, yes.
Yes, this is a question he need to hear this. He has grade 4 clubbing. He has also, because he has lung cancer like this is a question. And also about antitrypsin, alpha-1 antitrypsin deficiency. The question come like, when you suspect this patient may have alpha-1 antitrypsin, usually in patient who is not smoking, in young patient not smoking.
Family history.
Yes. We suspect this in this situation.
Yeah.
The last thing that we can add, when the patient discharge, they add the COPD discharge bundle. We have 5 points. When any patient with COPD need to be discharged from the hospital, we have 5 points. First, we need formal diagnosis, that the patient has a formal diagnosis of COPD with spirometry or CT scan. And smoking cessation, that's the patient has been referred to smoking cessation unit.
The clinic,
we need to check inhaler technique. We checked and documented that the patient now know how to use his inhalers, and then refer to pulmonary rehab, and this has been documented as well, that the patient will go for pulmonary rehab or attend the pulmonary rehab at least in the last 12 months. Then we'll give him self-management leaflet. We'll give him self-management plan, that if there is an exacerbation, how he can manage himself, what we call secure bag, that he had some antibiotic and additional medication in case if anything happened. So
it's
we
called
need to
COPD bundle. COPD bundle,
yeah.
Don't forget to add that to them, I think, the vaccination program.
Yeah. So any patient on discharge, we need to make sure that he had these bundles.
Yes. Thank you, Dr. Mayada. It's very common, and I think no diet without COPD case or questions, either long or short. No doubt about that. Let me revise for Dr. Muhi the grades of COPD. I wrote it in the chat box down, Dr. Muhi. Remember the numbers: 350, 80. Forced expiratory volume 1, more than 80, this is mild. 50 to 80, this is moderate. 30 to 50, this is severe. And less than 30, very severe. Okay, remember 350, 80. And by the way, 3 plus 50 equal 80.
Yes.
You might remember this equation if it comes to you. Okay, remember these numbers. It's very important, and this is the grade of COPD. Anything else, Dr. Miada? In the
Now they
question?
like also
That's
the
okay.
to making like these grades by exacerbation. They divide now the grade by exacerbation. So it is A, B, C, D also, like low risk exacerbation or high risk exacerbation with fewer symptoms or more symptoms.
Mhm. Okay, if you have it, Dr. Aisha, because I don't know this really in grade. If you have it, just share it to the
The
group.
most important to know that is what's the predictive of exacerbation. It is prior exacerbation, predictive of admission, prior exacerbation also. And it is simple, just it is A, B, C, D, low risk exacerbation with fewer symptoms, and low risk exacerbation with more symptoms. High risk exacerbation with fewer symptoms, and high risk exacerbation with higher symptoms. So low risk, it is less than 1 per year. High risk, more than 2 per year. This just
Okay, if still you have it as
table. Okay, I'll share
yeah,
you.
better, yes, because really I maybe this is something new guidelines. I'm not sure about. I didn't read about it before. But anyway, we are learning together here. Okay.
Okay.
Okay. Thank you, Dr.
The
Aisha.
problem, Dr. Rafi,
Uh,
for me, to collecting the signs with each other to put the diagnosis at the end. يعني some
practice, then practice. Even this session, however, you are not seeing patient. We are just simulating, but still, it will help you how to link between the finding and give a diagnosis.
يعني مثلا patient has
Okay.
obstructive lung disease picture and he
Okay.
has coarse crackles like
Good.
this.
Very good
Mm.
question. What do you think?
Yes, this is bronchitis example.
Yeah, COPD with
And
bronchiectasis.
they may be localized, not all the chest.
If localized, good question from Dr. Aisha. Localized with bronchial breathing. What is it? Still COPD, expiratory, long
Pneumonia
expiratory.
also. Yeah.
Yes, it's one of
Again,
the case.
wait, I don't understand.
Expiratory wheezes, how
Yeah.
all over, scattered expiratory wheezes,
Yes.
and in basal or one side basal inspiratory crackles, which is improving with cough with bronchial breathing.
Mhm. So
This
you'll
is
say bronchiectasis with obstructive lung disease.
no, it's not bronchiectasis. I said it change with not change with cough. Sorry.
Coarse crackles.
Yeah, fine in respiratory crackles, which is not
Fibrosis and COPD. So obstructive lung.
He means
pneumonia
that
with
some area of the lung is dull and has
yeah,
bronchial
yes,
breathing inside, and some crackles.
yeah,
Again, yeah,
One
Dr.
area.
Rabi.
One
One
area.
area.
You can
One area.
find one area only has bronchial breathing and the dullness on percussion and
yeah,
some crackles more than the other chest.
yeah.
So as this and the reduced air entry in this area.
Cavity and increase also vocal firmness.
Collapse. It should be collapse like this.
Collapse.
If you
Bronchial
see-
breathing, you will not hear bronchial breathing on collapse.
Yeah,
It will be pneumonia.
exactly, pneumonia. Bronchial breathing, cavitation, consolidation, or abscess.
Yes.
collapse
Yes.
also, يعني if there is
Collapse,
dullness,
no air entry at all.
No
You
air
will
entry
hear.
at all. Exactly. Yes.
the
You cannot.
area above the collapse, the area of the lung above this collapse, it will be bronchial breath.
Yes, 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 exactly.
So this example you said, what is the diagnosis?
COPD with pneumonia or with
Pneumonia.
with consolidation.
They will bring pneumonia in exam.
Yes, it comes in exam.
Mm.
So focus on auscultation. You might hear crackles in COPD patient. Suppose COPD patient will not have crackles, right? Just he will
Exactly.
have expiratory wheezes all over, bronchi all over, scatter expiratory bronchi all over the chest. But if you have heard crackles, this is not normal with COPD patient. Either bronchiectasis if it is coarse, or is it localized maybe as pneumonia or infection, ongoing consolidation, plus bronchial breathing you will hear. Some COPD patient, you will have increase, no resonance, I mean dullness, basally, and it comes in exam also. Basally, there is dullness and decreased air entry and increased focal phlegmatis. Increased. What is this?
Maybe effusion.
Yes.
Diffusion.
Yes, perfect.
If you find the patient has cannula and he is like a case of acute, suspect that is pneumonia or effusion, something. And
Yeah,
to notice the
something,
chest good, maybe there is
yeah,
side of
compromise. Exactly,
Yes.
compromise his breathing. So it's something need to be admitted for. Clear? We give you all example of CBD and exam.
They can bring يعني lung of TB, all the TB in the exam. They bring it before.
TB?
TB lung before.
No,
I
they
think
might bring
if they found,
fibrosis.
I think if they found someone like that,
It will be
maybe
destructive.
with
lung.
finding of fibrosis, yes, just
Yeah,
for
fibrosis.
differential,
Yeah, for
because you
differential.
will not
And
say
apical.
TB for.
Exactly.
Yes, I mean all the TB يعني
It
TB
will be
lung
for
يعني.
differential. If you find some sort of restricted movement of one side and the apical crackles, but the lung, the other field of the lung is good, so you can make like differential. I suspect there is fibrosis here. What is the cause of fibrosis? Maybe all the abscess, all the TB, ممكن
Yes.
rheumatoid, anything بقى causing apical fibrosis.
Yes, exactly. Okay, thank you, Dr. Aisha and Dr. Mahi, Dr. Mayada as well. Any question from others? Any comments? See, Dr. Mahi, after we were about to cancel the session, we spent
Yes, I about to say that. Nice session. Very
yes,
informative
and cocktail, neuro plus the chest. Really,
yes,
it's
thank you, really. Yes.
amazing session. Thank you also, Dr. Aisha. Thank you, Dr. Mayada. Also, she saved the session. She gave us the case today.
Thank you.
Thank you, everyone.
Was nice.
Yeah, nice, very nice. Thank you, Dr. Mayada.
Thank you.
Anyone has homework, please share it. Dr. Aisha, you have homework about these guidelines. And Dr. Mayada as well, she has homework about COPD bundle.
Okay.
Dr. Mahi, we can give him homework to read these things for his exam.
I'm not sure.
Yeah, best of luck, Dr. Mahi, inshallah, in your exam. Enjoy your weekend. Have a nice weekend, all of you. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
عليكم السلام.